Dan, are you there?
Hey, Len, I'm here.
Yeah, good morning. I see your slides, so everything looks good.
Okay, perfect.
The audience is growing. We'll wait a couple of more minutes. Some people listening probably don't know who you are because of COVID and the fact that people don't see one another in person. You might just say a word or two about who you are and where you came from to join the fellowship.
Sure, yeah. Yeah, do you want me to do that now or wait until?
Just wait a minute or two. And then Francis wants us to make sure that we end on time. Then the rest of us, I'll jump over to the board review and the rest of the faculty will go over to the faculty meeting.
Sounds good.
I've got 6:58.
Yep, me too.
Well, it's virtually 7 o'clock. Let's go ahead and get started because I've asked Dan to make sure he finishes on time. This is going to be on EGPA and GPA, what we used to call Wegener's and Scherg-Strauss. And I think these diseases, especially EGPA, is becoming much more our disease since the introduction of anti-eosinophil biologics, which are pretty much uniquely used by us and not by rheumatologists, who probably were the main ones to treat these diseases before. So it's 7 o'clock. Let's go ahead. Dan?
Okay, thanks, Len. So yeah, I'm Dan. I'm one of the first year fellows this year. So just as a short introduction, I practiced general pediatrics for 2 years in Brooklyn, New York for the last 2 years prior to coming here. But originally I'm actually from the Midwest. I'm from Minnesota. All right, so I'll be, as Len said, I'll be talking about ANCA-associated vasculitis today, specifically GPA and EGPA. So as you can imagine, it's going to be a very broad overview since each of these topics could easily take up far more than an hour. As a sort of disclaimer, I should mention I actually have yet to see or manage either of these diseases. So preparing this talk really served as my own introduction to the topic, and maybe it will be more of a review for everybody else. But before I start, I was asked to remind everyone to please mute yourselves during the talk. And I have nothing to disclose. So before specifically getting into EGPA and GPA, I first wanted to zoom out and look more broadly at vasculitis to see where these fit in. So in this figure, you see the large vessel vasculitides on the left, which include GCA and Takayasu. Within medium vessels, you have polyarteritis nodosa and Kawasaki. And then within the small to medium vessels, it's divided into two categories. So those that are associated with immune complexes and those without, which is also called posse-immune. So those with immune complexes include cryoglobulinemia, IgA vasculitis, and hypocomplementemic urticarial vasculitis, which we also sometimes see in the allergy world. The posse-immune ANCA-associated vasculitides are our focus today. So these include GPA, MPA, and eGPA. I don't really have time to get into MPA today, but know this is closely related to GPA. And even though these are called ANCA-associated vasculitides, which I'm just going to call AAV from now on, the ANCA itself isn't required. And indeed, a sizable minority of patients do not have a positive ANCA. So this is just a very basic and somewhat crude illustration of the two types of ANCA commonly seen in AAV. So imagine these cells are both neutrophils. On the left is indirect immunofluorescence of C ANCA. The C stands for cytoplasmic, which is obvious here as the fluorescence lights up the entire cytoplasm. So this corresponds to antiproteinase 3, or PR3, which would be seen on ELISA. On the right is immunofluorescence of P ANCA. So P stands for perinuclear, which is visually represented here around the nucleus. So that's perinuclear. P ANCA corresponds to anti-myeloperoxidase, or MPO, on ELISA. So remember that the ELISA assays have substantially higher specificities and positive predictive values than the immunofluorescence patterns. So you should always be ordering the ELISA. More on this later, but GPA is more often associated with C ANCA, and eGPA is more with P ANCA. But again, either ANCA could be seen in either disease. So the high percentage of patients with AAV that have positive ANCA has raised questions about its possible role in pathophysiology. So one theory is that because PR3 and MPO are enzymes that reside in the granules of resting neutrophils, they're normally inaccessible to antibodies. But when the neutrophils are exposed to cytokines like TNF or IL-1, the enzymes translocate to the membrane, and it's there that they can interact with ANCA, and this activates the neutrophils. So that releases factors, O2 free radicals, cytokines generating C5a, and those neutrophils kill endothelial cells. And there's some evidence for this theory in mice, apparently. So still, many observations actually argue against a primary role for ANCA in the pathogenesis. For instance, patients can have active disease in the absence of ANCA, while some patients in remission may continue to have high ANCA titers. Also, it's not clear how ANCA could cause granulomatous inflammation. So really the precise role of ANCA remains to be defined. And last slide on ANCA specifically, but this is just to show that ANCA is by no means specific for ANCA-associated vasculitis, as there are many other entities with positive ANCA. On the flip side of that, as I already mentioned, there are plenty of cases of ANCA-negative, but ANCA-associated vasculitis. So finally, I'm going to get into the specific diseases, starting with GPA. So this is just the official Chapel Hill vasculitis classification criteria for GPA. It states that GPA is a necrotizing vasculitis with few or no immune deposits. Again, that's posse-immune, affecting mostly small to medium-sized vessels, and has granulomatous inflammation, especially of the upper and lower respiratory tract. Notice that ANCA is not part of this definition. In terms of epidemiology, GPA is rare. The incidence is about 4 to 15 per million, but it actually seems to be increasing. It's not clear if the true number of patients is increasing now, because the rise might be secondary to improved recognition. So GPA usually affects older adults with a mean age of diagnosis at 40 years, but it can be seen really in any age. It's seen equally in males and females, and in terms of ethnicity, it's seen more in Caucasians. However, with some increasing data collection, more recently, large cohorts are now being described in, especially in Asian countries. So the pathogenesis of eGPA is not clear. The possible role of ANCA, I already discussed. Genetic factors are also under investigation. So one theory is GPA may be an aberrant cell-mediated immune response to an exogenous or endogenous antigen in the respiratory tract. The granulomatous involvement of the respiratory tracts point to this possibility. Additionally, some in vitro studies point toward excessive Th1 and Th17 cytokines, as there is evidence of increased interferon gamma and TNF by CD4 cells in active disease. In addition, there's evidence for skewed Th17 responses. So moving on to diagnostic criteria. So there have been multiple attempts to define GPA without biopsy because a prompt diagnosis is often important for initiating treatment. So the American College of Rheumatology established criteria in 1990, which allows diagnosis without biopsy. It's often used clinically. However, we should remember this was initially made for research purposes and was not really intended to be used in this way, even though it commonly is. So the criteria include nasal or oral inflammation. That could include painful or painless oral ulcers or purulent or bloody nasal discharge. The others are abnormal chest radiograph, commonly showing nodules, fixed infiltrates, or cavities. The third is abnormal urinary sediment. That's often microscopic hematuria with or without red cell casts. And then the fourth is granulomatous inflammation on biopsy. So because it requires 2 out of 4 criteria, the biopsy isn't required in this set of criteria. So the presence of 2 or more yielded a sensitivity of 88% and a specificity of 92%. So getting into clinical features now. First, these are just the general symptoms of any systemic vasculitis, and really you could be talking about any systemic inflammatory disease here. So fevers, musculoskeletal complaints, fatigue, anorexia, weight loss. One exception would be the limited forms of ANCA-associated vasculitis, including renal limited and ENT limited. I'm not really going to be talking about these today, but those forms would usually have fewer of those systemic symptoms. And the duration of these prodromal nonspecific symptoms can be over the course of weeks or months prior to any evidence of specific organ involvement. So now looking broadly at GPA clinical features. So any organ system can be affected with vasculitis or granulomatous changes, but here are the most common ones. So greater than 90% of GPA patients seek medical attention due to upper and lower respiratory symptoms. Virtually all patients have upper airway or pulmonary involvement, and the majority have both. ENT involvement is seen in 92%. Pulmonary involvement is seen in 85 to 90%. In terms of non-respiratory manifestations, renal disease eventually develops in 80%, but it's rarely the presenting symptom. The others listed will also go through. So specifically looking at ENT issues, most commonly you might see paranasal sinus pain and purulent drainage. Chronic sinusitis is common. You might see a presentation of sinusitis that fails to respond to antibiotics. Unlike in EGPA, you do not see nasal polyps often. Otitis media or serous otitis are also common, and hearing loss could be seen. Sometimes you'll see bloody nasal discharge, crusting, and nasal mucosal ulceration. A septal perforation may follow secondary to the erosion of the nasal cartilage, and that results in a saddle nose deformity, which this picture illustrates. This is another feature distinguishing GPA from EGPA, where you don't see it as much. This CT image demonstrates tracheal stenosis. So this happens in either active disease or later due to scarring, and it happens in about 20% of GPA patients. It's usually seen after other manifestations, but rarely it can be the presenting feature. So this would present with stridor, dyspnea, and possible voice changes, as you can imagine. The stenotic area is usually limited to the subglottic trachea, and it results from inflammation and fibrosis. In those who develop this, 50% present when their disease is otherwise quiescent. So regarding eye involvement, you can see things like conjunctivitis, scleritis, and episcleritis. On the more extreme end, it might present as seen in this CT, which is an example of mass effect from a retroorbital pseudotumor causing proptosis. So that would present as abrupt loss of vision through compression of the optic nerve. So moving down to the lower respiratory tract, in GPA, lung involvement could have symptoms ranging anywhere from asymptomatic to cough, hemoptysis, dyspnea, chest discomfort, or some combination of those. The most common thing you might see are multiple bilateral nodular cavitary infiltrates. This is seen anywhere from 40 to 70% of patients. These nodules can range in size from just a few millimeters to up to 10 centimeters. The larger nodules that are over 2 centimeters usually cavitate, and hemorrhage can occur around the nodules. If you biopsied these, you would see necrotizing granulomatous vasculitis. A less common form of lung involvement is diffuse alveolar hemorrhage. That's seen in about 10% of cases. With this, you would see ground glass infiltrates, which can coalesce into a hemorrhagic consolidation. You'll see kidney involvement in 80% of GPA patients. It's usually within the first 2 years of disease onset. It is more common in ANCA positive patients, but there's a subset with ANCA negative glomerulonephritis. So on one end of the spectrum, you could see asymptomatic hematuria with normal renal function. In other cases, you might see variable proteinuria, which is usually subnephrotic. On the more emergent end, you could see rising creatinine over days or weeks. You could see hematuria and CAS, along with hypertension and edema. Obviously, this requires urgent therapy. So here's a kidney biopsy demonstrating post-immune necrotizing glomerulonephritis. About 1/2 of patients with GPA do have skin involvement. So again, this can be a range of things. The most common skin lesion is leukocytoclastic angiitis, which causes purpura of the lower extremities as seen here. These lesions can have focal necrosis and ulceration. Other skin lesions include urticaria, levator reticularis, and nodules. More rarely, patients have erythema nodosum, pyoderma gangrenosum, and Sweet syndrome. Just to touch on other organ involvement, in GPA, peripheral nerve involvement is seen in about 15%. This is more often seen in EGPA, as we'll talk about later. The presence of this is associated with a worse prognosis, with patients more likely to fail initial treatment with steroids alone and require additional immune suppression. You could potentially see sensory neuropathy, cranial nerve abnormalities, CNS mass lesions, and sensory neural hearing loss. In all AAV, patients also have a high incidence of DVT, and it's not entirely clear why. Here's just a list of other organ systems that are less commonly involved. So the differential diagnosis is obviously very broad, especially early on with vague symptoms. Distinguishing AAV in general from other systemic rheumatic disease is often an issue, but the availability of c-ANCA has dramatically improved our ability to distinguish GPA from other conditions. One thing I wanted to point out on this list is that anti-glomerular basement membrane disease, of course, is your other big pulmonary renal syndrome. Remember that this is far more rare than AAV. Also note that occasionally you can see anti-GBM antibody disease along with AAV. So ideally, the diagnosis of GPA is made by the clinical features we discussed, along with characteristic biopsy findings, as most lab findings are non-specific, just reflecting systemic inflammation. To help exclude other processes, you'll obviously want to send studies like ANA, anti-GBM antibodies, C3, C4, cryoglobulins, and others. So because of potential asymptomatic renal involvement, the UA is also very important. In some cases of GPA, a biopsy is not feasible or it should be delayed. And because a prompt diagnosis is important to permit starting potentially life-saving and organ-sparing therapy, a presumptive diagnosis can sometimes be made. This is where ANCA can be very helpful. Remember that most GPA patients have a PR3 ANCA. However, up to 20% have MPO ANCA, and at least 10% are actually ANCA negative. So the sensitivity and specificity of PR3 ANCA are both high, but the predictive value is highly dependent on the clinical setting. Also note that even though ANCA titers can parallel disease activity, it's not consistent enough to allow management based on serial ANCA levels alone. For imaging, remember that a CT chest is recommended because it discloses lesions that are not seen on X-ray, particularly behind the diaphragm. Sinus CT is often abnormal, as are lung function tests. BAL is sometimes done if there is a suspected alveolar hemorrhage. So regarding your biopsy site options, an open lung biopsy is the gold standard as it's diagnostic in 90% of cases. These other options are less invasive, but do have less specific findings. Still, these options should be considered if a lung biopsy is not feasible. So on to treatment, finally. Untreated GPA is generally lethal, with a mean survival time of 5 months. The effect of steroid treatment alone has not been fully defined, but one very old, widely quoted paper looked at 26 cases in the 1950s and 60s, which showed that steroids did prolong survival. In 1973, the now famous Anthony Fauci and his colleagues at the NIH reported on induction of remission in 12 GPA patients treated with daily cyclophosphamide along with steroids. Subsequent larger cohorts confirmed efficacy of this combination in inducing remission in 80 to 100% of patients. Unfortunately, through extended follow-up, it became apparent that relapse did occur in about 50 to 70% of patients, despite successful induction therapy. We also know cyclophosphamide causes many problems, including major infections, infertility, myeloproliferative disorders, cystitis, and transitional cell carcinoma of the bladder. Despite the toxicities, these two agents remain the backbone of induction therapy. So the approach to initial therapy depends on the severity of disease and the organ systems involved. Specifically, organ or life-threatening features include alveolar hemorrhage, glomerulonephritis, CNS involvement, GI bleeding, and cardiac disease. So non-severe disease alone, such as sinusitis, skin, joint, or lung involvement, without respiratory compromise, could be treated with less toxic regimens. For patients with severe active GPA, options for induction include steroids combined with either cyclophosphamide or rituximab, which I'll get into in a second. So prednisone is usually started at 1 mg per kg per day, continued for a month, and then tapered. For patients with life-threatening disease, you would often start with high-dose pulse steroids first. When cyclophosphamide is needed for induction, it can be either daily oral or IV pulses. Both are effective at inducing remission, but the daily oral regimen has been shown to have a lower rate of relapse, at least in the case of GPA. This agent is given for 3 to 6 months and then switched to a less toxic agent for maintenance. So rituximab, as you know, is a chimeric monoclonal antibody against CD20. So it targets B cells, and its use has been shown to be efficacious as an induction agent and can allow avoidance of Cytoxan. A randomized double-blind placebo-controlled trial called the RAVE trial compared the two agents, rituximab and cyclophosphamide, and it demonstrated non-inferiority of rituximab. So this did lead to FDA approval for its use in GPA. Given the equivalent efficacy, the decision on which agent to use is really patient dependent. So for remission maintenance, data supports comparable efficacy of methotrexate or azathioprine after cyclophosphamide. MMF or rituximab every 6 months are also options. So finally, there are a number of targeted therapies under investigation in GPA, which I don't really have time to get into. So without treatment, the prognosis of GPA is bleak, with a 93% mortality at 2 years. Death can occur rapidly with progressive lung disease. More limited forms do have a better prognosis, and some even have spontaneous remissions, but that's certainly not the norm. Fortunately, with treatment, 90% of patients have marked improvement or at least partial remission. 75% have complete remission over the course of 12 months on average. Of those patients, 50% do eventually relapse. 13% of patients die despite maximal therapy, and given the toxicities of these medications, 40 to 50% experience serious infectious complications during treatment. And many of these patients are on Bactrim. So shifting gears to EGPA now. So here's the official Chapel Hill definition of EGPA. So as you can see, the distinguishing feature really is the prominent eosinophilia, but it also has necrotizing granulomatous inflammation of the small and medium-sized vessels, just like GPA. So the epidemiology of EGPA is also unclear, partially because of the uncertainties related to diagnosis, but it's likely very rare. Among AAV, EGPA seems to be the least common, making up just 10% of all vasculitis. In the US, prevalence is approximately 18 per million. The mean age at diagnosis is 40 years, and though it's rare in children, when it does occur, it follows a more aggressive course. And there is no gender predominance in EGPA. So the pathogenesis of EGPA is also uncertain. The strong association with asthma and eosinophilia does point to a prominent role for the eosinophil with likely increased recruitment and decreased apoptosis. The allergic features suggest heightened Th2 immunity. Indeed, there's some evidence for this, with some in vitro studies showing overproduction of Th2 cytokines. A decrease in T regulatory cells has also been demonstrated. Finally, ANCA could play a role, as I discussed earlier. So just a few other things to mention regarding pathogenesis of EGPA. Genetic factors may play a role here, as evidenced by some studies showing specific HLA types, which are more prevalent in EGPA. And also there is a genome-wide association study identifying genetic distinctions between ANCA positive and ANCA negative disease. Development of EGPA has also been associated with several asthma medications. However, this association is most likely due to unmasking of an already present EGPA in the setting of steroid weaning in severe asthma. Alternatively, it could sometimes seem this way due to the need for intensification of asthma therapy for someone with escalating EGPA. So it's really not felt to be a causal relationship. Finally, an EGPA-like illness can rarely occur after the use of free base cocaine. This is an ANCA-associated vasculitis, but the ANCAs here recognize different target proteases. So the ACR criteria for EGPA were developed in 1990. Like the ACR criteria for GPA, it's good to remember these were designed and validated only for research studies and weren't intended as diagnostic criteria. But still, these are widely used in practice. So there are 6 criteria, and the presence of 4 or more has a sensitivity of 85% and a specificity of 99.7%. These criteria include asthma, eosinophilia of greater than 10%, mononeuropathy or polyneuropathy, migratory or transient pulmonary opacities, a paranasal sinus abnormality, and finally biopsy, which has to contain a blood vessel showing the accumulation of eosinophils in extravascular areas. So using this criteria, you could potentially make a diagnosis without a biopsy. Okay, moving on to EGPA clinical features. So the vast majority will present with this classic triad of chronic rhinosinusitis, often with polyps, asthma, and prominent eosinophilia. The vasculitis manifestations come later. When it does come, you could potentially see involvement of many organ systems, just like in GPA. Broadly, these include the lungs, the skin, cardiac, which is more common in EGPA versus GPA, kidneys, which is less often than in GPA, and the peripheral nervous system, which is more so than GPA. So the clinical features typically develop in sequential phases, but these are not always clearly distinguishable. First, the prodromal phase usually occurs in the second and third decades of life, and it's characterized by atopic disease, allergic rhinitis, and asthma. So if you see new onset asthma in adults, EGPA should always be a consideration. The eosinophilic phase comes next. Here you'll see peripheral eosinophilia and eosinophilic infiltration of multiple organs, especially the lung and GI tract. So finally, the vasculitic phase. This usually develops within 3 years of the onset of asthma, but it could be delayed for several decades. This is life-threatening and may be preceded by nonspecific constitutional symptoms. Now to go through some of the specific organ systems, starting with ENT involvement. So this affects 80% of patients. Here you could see serous-otitis, allergic rhinitis, recurrent sinusitis, and nasal polyposis. Remember this, the polyps would distinguish EGPA from GPA, where polyps are really not often seen. So looking at this constellation of symptoms, notice this looks a lot like AERD. Indeed, prior to the onset of eosinophilic infiltration of other organs, the clinical features overlap considerably. Also remember, necrotizing lesions of the nasopharynx and upper airway are more characteristic of GPA, as we talked about before, and these are unusual in EGPA. So asthma is the cardinal feature of EGPA, or the cardinal clinical feature at least, and it is present in more than 90% of patients. It usually precedes the vasculitic phase by about a decade. EGPA is typically suspected in patients whose asthma is poorly controlled on moderate doses of inhaled steroids. Many require frequent or long-term courses of systemic steroids. As the vasculitic phase begins, the asthma severity might increase, and more rarely, it might actually decrease. Prolonged treatment of asthma with steroids might suppress the usual clinical signs of EGPA. So the disease may not become evident until the steroids are stopped. Other pulmonary findings are reported in 50 to 70% of patients. These include pulmonary opacities with eosinophilia. These can resolve spontaneously and are present in up to half of patients. Pleural effusions, which are often eosinophilic, and nodules. And remember, these are rarely cavitary, unlike in GPA. Also, unlike GPA, alveolar hemorrhage is rare. When present, it's usually associated with ANCA positivity. And remember, the rate of venous thromboembolism is increased in all ANCA-associated vasculitis. So regarding neurologic features, a peripheral neuropathy affecting at least 2 separate nerve areas, which is also called mononeuritis multiplex, is seen in up to 75% of EGPA patients, making it the most common extrapulmonary manifestation. So this This presents with pain, numbness, and/or weakness. Untreated, it can progress to a symmetric or asymmetric polyneuropathy. A severe neuropathic pain could accompany this, and these patients are more likely to have a positive ANCA. CNS manifestations have been reported, including subarachnoid and cerebral hemorrhage, cerebral infarction, and cranial nerve palsies. However, these are less common. Ophthalmic manifestations can include central retinal artery or vein occlusion, ischemic optic neuropathy, and conjunctival nodules. So skin involvement is one of the most common features of the vasculitic phase. Half to 2/3 of patients have skin lesions, which usually appear as tender subcutaneous nodules on the extensor surfaces of the arm, particularly the elbows, hands, and legs, as seen here. Biopsy of these lesions usually reveals granulomas. So skin lesions can also appear as a macular or papular erythematous rash or hemorrhagic lesions, including petechia, palpable purpura, and extensive ecchymosis, as in almost any vasculitis. Cardiac involvement is one of the serious manifestations, and this accounts for about 1/2 of deaths attributable to EGPA. This occurs in 10 to 40% of patients, and that's often enough that all patients with suspected EGPA need some degree of screening for this. Clinical manifestations could include signs of heart failure or pericarditis, and also cardiac rhythm abnormalities. So patients with cardiac involvement are less likely to have a positive ANCA and more likely to have higher peripheral eosinophils. The frequency of renal involvement is between 20 to 50%. Compared to GPA, it occurs less often and is usually less severe, but the severity does vary from isolated proteinuria or microscopic hematuria all the way to a rapidly progressive insufficiency. Those who undergo biopsy may demonstrate a necrotizing glomerulonephritis. And remember, a positive ANCA is almost always present in EGPA patients who have renal manifestations. Systemic hypertension affects about 10 to 30% of patients with EGPA, and this could reflect renal involvement, or it could be a complication of steroid therapy. To just touch on a few other systems, an eosinophilic gastroenteritis can be seen in up to 1/3 of patients. This could precede or coincide with the vasculitic phase. These patients can have abdominal pain, diarrhea, GI bleeding, and colitis. In terms of musculoskeletal symptoms, about 40 to 50% of patients in the vasculitic phase can have these symptoms, such as myalgias, migratory polyarthralgias, and less commonly, a frank arthritis. Finally, an eosinophilic lymphadenopathy has been noted in about 30 to 40% of patients. Here you might see cervical and axillary nodes up to 3 centimeters. So the differential of EGPA really gets into our differential of hypereosinophilia, which we're all somewhat familiar with. Because of the overlapping respiratory components, we're thinking more about things like AERD, eosinophilic pneumonia, and ABPA, but we also have to think of other causes. So just to touch on a few of these, like I mentioned before, AERD is your classic triad of asthma, chronic rhinosinusitis with polyps, and reactions to NSAIDs. To distinguish EGPA, look for other organ involvement and possibly the ANCA positivity. Sometimes AERD may evolve into EGPA, so that's important to remember with your AERD patients. Chronic eosinophilic pneumonia alone would lack granulomas on biopsy. Patients would also not be expected to have ANCA positivity and would not have other organ involvement. But occasionally, this can precede the other manifestations and also evolve into EGPA, So these could sort of exist on a spectrum. ABPA could also look pretty similar with asthma, X-ray opacities, and maybe rhinosinusitis and eosinophilia. A normal serum IgE would pretty much eliminate this from your differential. And other organ involvement would also distinguish eGPA. So in the hypereosinophilic syndrome, patients might have cough. A minority could have X-ray opacities, but asthma is rare. When a clear differentiation here cannot be made, molecular testing for the FIP1L1 PDGFR alpha mutation might be helpful. Obviously, you have to think of other vasculitides, including GPA, but the degree of eosinophilia, type of ANCA, and presence of asthma distinguish eGPA. Finally, think of all the other causes of eosinophilia. Get a good medication history, get a travel history, and consider stool and serologic studies for parasites. Remember not to start steroids if you're concerned about strongyloidiasis due to the risk of hyperinfestation syndrome. If you're concerned about this, check the ELISA study first. HIV testing might be indicated. For possible neoplastic causes, you may want to check a peripheral smear, B12 and tryptase, but if you're truly concerned, you'll be sending to hematology for a bone marrow biopsy. The mutation studies I mentioned could be helpful too. Having said all of this, a biopsy is the most important study to distinguish eGPA from all other possibilities. So there are no specific lab tests for eGPA. As in GPA, you'll see non-specific markers of inflammation. You can also have hypergammaglobulinemia. You could see a positive rheumatoid factor or an ANA at low titer, and you could have either normal or elevated complement. Only 40% of patients with eGPA have a detectable ANCA, which again is usually anti-MPO. Unlike in GPA, ANCA is not sensitive or specific in eGPA, but the disease manifestations can differ between positive and negative ANCA. So it can be helpful in predicting disease phenotype. A positive ANCA, again, is associated with renal involvement, peripheral neuropathy, and biopsy-proven vasculitis, while the negative ANCA is more associated with refractory asthma and heart disease. Once eGPA has been diagnosed, patients should be screened for kidney, heart, GI, or peripheral nerve involvement, as these are associated with a poor prognosis. Just a few things to highlight here. So initial cardiac testing is performed even in the absence of symptoms because it's the leading cause of mortality. It should typically include BNP and troponin, EKG, and usually a transthoracic echo. Further testing then would be based on the results of these screens. In terms of GI and nerve testing, this can be done if symptoms point to it and are not always needed. In terms of imaging, high-res CT of the chest will give a better idea than X-ray of what's actually going on, including picking up micronodules, septal or bronchial wall thickening, and bronchial dilation. This can also guide the choice of a location for BAL or biopsy if needed. Sinus CT changes are common, but unlike in GPA, you should not see bony erosions. And you're more likely to see polyps, as I mentioned. So spirometry might be consistent with asthma, but when lung parenchymal involvement occurs, volumes might be decreased and you may have gas transfer abnormalities. If performed, BAL fluid may have a high percentage of eosinophils. However, this is not a specific finding and would only be present with active pneumonitis. So histologic confirmation is ideal, but it's not always possible. The biopsy site is usually selected from the least invasive options that's most likely to yield a diagnosis. As an example, when either skin disease or peripheral neuropathy is present, one of these less invasive sites is often preferred. However, the sensitivity does vary considerably. So for peripheral nerve, the sensitivity is 50%. For sinus biopsy, it's 35%. Lung biopsy would be the most sensitive, but it's obviously the most invasive. For this reason, it's reserved for situations in which none of the extrapulmonary sites is appropriate. The high-res CT shows parenchymal involvement, and treatment decisions would be altered by the results. Before getting into specific treatments, you do have to know how to score disease severity, as this is how we make standardized decisions about who should get cyclophosphamide and who may be okay with steroids alone. The 5-factor score was devised in 1996 and then revised in 2011. The revised score here on the right includes age over 65, cardiac insufficiency, GI involvement, renal insufficiency, and the absence of ENT manifestations, because the presence of this is associated with a better prognosis. So the presence of each factor here is given 1 point, and the score ranges from 0 to 2. A score of 0 means none of the factors are present. A score of 1 for if you have 1 factor, and you get a score of 2 for 2 or more factors present. So this scoring system has also been correlated with prognosis. However, prognosis has changed over time with new treatments and also with earlier detection. For instance, in the 1990s, a 5-factor score of 1 or greater was associated with a 30% mortality at 5 years. Subsequently, survival has improved and is now closer to 10% at the same score of 1 or higher. With remission being the goal of treatment, most studies define remission as the absence of clinical manifestations on minimal prednisone. And that's the minimal prednisone is usually defined as 7.5 milligrams per day or less. Because ENT and asthma flares may not reflect vasculitis activity, these particular symptom flares are sometimes excluded from this definition. So relapse is generally defined as the recurrence or worsening of symptoms requiring an increase in steroids or other immunosuppressives. Most patients will have pulmonary symptoms at relapse. In terms of monitoring, it's important to follow up about every 3 months. You'd be looking closely at symptoms, the eosinophil number, pulmonary function tests, any previously abnormal labs. For instance, if you had an abnormal UA or creatinine, you'll follow those, and ANCA positivity. Again, the ANCA positivity can reflect disease activity, but not consistently enough to use by itself to determine changes in therapy. And that goes for GPA as well. So there are unique aspects to therapy in eGPA compared to GPA. In eGPA, steroids alone can be very effective for many patients, which is generally not the case in GPA, where usually you'll use another immune suppressive agent along with steroids for induction. In eGPA, you would start with high doses of oral prednisone, about 40 to 60 milligrams daily, in order to get into remission as quickly as possible. Then you would taper after the first month or so. However, dose tapering is often limited by asthma, and many patients need low-dose prednisone for persistent asthma, and it's very difficult to wean. In those with fulminant multi-system disease, most experts would recommend induction treatment with steroids plus cyclophosphamide for 3 to 6 months. This would be followed by a maintenance agent similar to in GPA. In eGPA, cyclophosphamide is recommended in patients who have a 5-factor score of 2 or higher. Survival is significantly prolonged in these severe cases if they're treated with both agents compared to steroids alone. Some even use this agent with a 5-factor score of 1, particularly if there's cardiac or CNS involvement, as there's a higher mortality compared to those with a 5-factor score of 0. However, an alternative regimen for a 5-factor score of 1 would be steroids plus azathioprine or methotrexate. For use of Cytoxan in eGPA, like we talked about in GPA, You could do either daily oral dosing or once monthly IV dosing. There's less preference in the case of eGPA as we currently have insufficient data. Similar to GPA, sometimes high-dose IV steroids, usually methylprednisolone, is needed in severe disease or those unresponsive to prednisone plus another immunosuppressive for remission. Some retrospective series have suggested benefit of rituximab in eGPA, but the evidence here is currently not as strong as it is for GPA. So this agent shouldn't replace cyclophosphamide in severe eGPA, and especially not with cardiac involvement. So most recently, there has been investigation of mepolizumab. This is, as you know, it's an anti-IL-5 agent, and this was prompted by the prominent role of the eosinophil in eGPA. As you know, IL-5 is a cytokine that regulates the growth, activation, and survival of eosinophils. As I mentioned earlier, IL-5 levels are increased in eGPA and associated with disease activity. So mepolizumab is a humanized monoclonal IgG1 antibody that binds free IL-5 with a high specificity and affinity, so it can't bind its receptor. This agent was first approved as add-on maintenance therapy for severe eosinophilic asthma, and it's been very effective in reducing eosinophil numbers in many patients with hypereosinophilic states. So after promising pilot studies in eGPA, a randomized trial was conducted in which mepolizumab 300 milligrams per month given subcutaneously was found to provide benefit in eGPA. This was called the MIRA trial, results of which were published in the New England Journal in 2017 and led to FDA approval of this agent in certain cases of eGPA. Many of you probably know a lot of these details. I'm still going to go through it mostly for myself and for the other fellows. So this was a multi-center trial of 136 patients with relapsing or refractory eGPA, randomly assigned to receive mepolizumab 300 milligrams or placebo every 4 weeks for 52 weeks. So to be included, patients had to have an eGPA diagnosis for at least 6 months based on a history of asthma plus eosinophilia, plus 2 additional features of eGPA. They also had to have a history of relapsing or refractory disease and be on a stable dose of prednisone, anywhere between 7.5 milligrams to 50 milligrams daily. So if they were on more than 50 milligrams, they didn't qualify. If they're on less than 7.5, they did not qualify for this study. They could also not be on Cytoxan, but if they were on other immunosuppressive therapy, the dose had to be stable for 4 weeks. Their primary endpoints were total accrued duration of remission over the study period and the percent of patients in remission near the end of the study. A secondary endpoint was average steroid dose near the end of the study. So the results showed that mepolizumab led to significantly more accrued weeks of remission than placebo. 28% of those on mepolizumab achieved remission over 24, actually 28% of those on mepolizumab achieved over 24 weeks of accrued remission versus 3% of placebo patients. Additionally, 44% of mepolizumab treated patients were able to taper their prednisone down to 4 milligrams per day or less. And that was compared to 7% of placebo patients. So it really reached its primary and secondary endpoints, and this led to FDA approving this agent for eGPA in 2017, joining its prior indication for eosinophilic asthma. So despite these good results, the authors did note that 47% of patients in the mepolizumab group did not achieve remission. So while it's a great option for add-on therapy in certain patients, it's certainly not a slam dunk. Note that the approved dose of 300 milligrams monthly is higher than the 100 milligram monthly dose, which was approved for severe asthma. Whether the 300 milligram dose is superior for eGPA was not studied. So overall, the data available support the addition of mepolizumab to daily steroids if patients' disease is not controlled with oral steroids alone, particularly with persistent or relapsing asthma or sinus disease. And remember, there's limited experience with this agent for the vasculitic manifestations. Also, the 5-factor score is less than 2, and the patient does not meet criteria for cyclophosphamide. as patients with severe organ-threatening features were also not included in the trial. So our data regarding mepolizumab's adverse effects really comes from the asthma population with over 1,500 asthma patients in clinical trials on this agent. So there have been no deaths, and the side effect profile has been found to be similar to placebo, really. And the majority of side effects are of mild severity. And notably, no neutralizing anti-mepolizumab antibodies have been detected thus far. Just to touch on more experimental therapies. So the other anti-IL-5 agents are obviously not as far along as mepolizumab, but preliminary evidence does suggest that reslizumab and benralizumab may also be beneficial. Other agents that have been looked at but are not standard of care include MMF, IVIG, hydroxyurea, interferon alpha, omalizumab, and plasma exchange. So with all that said, the prognosis of EGPA is favorable with treatment, with a 10-year survival rate of 79% in one study. About a third of patients attain long-term remission following therapy. Relapses are more common in patients with a positive ANCA, but remember that ANCA alone cannot be used to guide management. Without treatment, the prognosis is not good, with a 5-year survival rate of 25%. About 50% of untreated patients die within 3 months of the vasculitis onset. Most deaths would result from heart involvement in the vasculitic phase, but could also be due to cerebral hemorrhage, renal failure, GI bleeding, and status asthmaticus. So for me, this was quite a whirlwind of ANCA-associated vasculitis, especially given I've yet to see or manage this. From the general reading I did, here are a few of my take-home points. So one, there's enormous overlap among the different vasculitides, and especially with EGPA, there's overlap with other allergic disease. So sometimes there are unclear boundaries between EGPA and other hypereosinophilic disorders. So awareness of some of the key features is very important, especially because rapid treatment is paramount in improving morbidity and mortality. Two, remember that no single test makes a diagnosis of vasculitis, but in the case of GPA, a C-ANCA is fairly sensitive and specific in the setting of other suggestive features. A biopsy is still important to try to obtain if feasible, though. Whether an EGPA diagnosis can be made without ANCA and without demonstration of vasculitis has been a matter of debate, and it adds to the difficulty of EGPA classification. And three, in terms of future directions, obviously many of the current therapies we went over are associated with significant morbidity, but thankfully we do have some new targeted therapies, such as mepolizumab, that can be steroid sparing and don't have the toxicities of many of the agents used historically. So in addition to working on more targeted, less toxic therapeutic options, other future directions will hopefully include better markers to help identify patients with eosinophilic asthma who may be prone to developing vasculitis. Until that happens, we have to keep a low index of suspicion. So these are my references. And the word of the day is syndrome. I think we're just about out of time, but if anyone has questions, let me know.
Dan, thank you. That was very well done. A lot of ground. I'm just curious, for a long time, either I didn't recognize this disease or, and since we've had the introduction, especially of mepolizumab, now I have a cohort of people with this disease. So I don't know if that's awareness on my part or the disease is increasing, or now that we have a biologic for this, more of these people are being seen by allergists and then by rheumatologists who traditionally have followed vasculitis. So Just curious, other people's experience out there. I can think of at least 3 people that I'm treating for this now. What's the experience of other people? Anybody?
Yeah, I mean, I think the data says, it's not increasing in incidence. It probably is a referral bias that they're now coming to us. I think, also, Dan, this is a great overview, but one thing that's worth saying about cyclophosphamide versus mepolizumab, I mean, without going through all the data, I really think in the not too distant future, mepolizumab is going to be standard of care first-line therapy after steroids for these guys. Despite decades of literature around cyclophosphamide, there aren't really good studies. They're all just prospective studies, and there haven't been head-to-head comparisons with mepolizumab. But mepolizumab is by just sort of the numbers in those studies, equally effective, if not more effective, and much safer. And of course, in that New England Journal study, they had to exclude people who were on cyclophosphamide or eligible for it, because that's how you had to design the study. But, if you talk to Mike Wexler or others, he's the one who ran that study, they really, the stress is around anti-IL-5 therapy. And, I think the others will be, they're being studied now. So just as a take home, when these patients are coming to us, I would strongly suggest consideration of an anti-IL-5 treatment before you think about, a highly toxic thing like cyclophosphamide.
And I would add also that the patients that I tend to see, they usually come to us because of worsening asthma, and EGPA, of course, has many other presentations. But I guess there's also a bias of the phenotype of EGPA that we see. That's the patients with underlying known asthma and maybe chronic sinusitis. I don't see as much of the cutaneous symptoms, for example.
Question. I was taught that these things will almost always have a positive SED rate. How common is a normal or near normal SED rate in ABPA?
That's a good, I did not come across that in my reading for this, but it's a good question.
I mean, my comment would be a SED rate is so non-specific, I'm not sure how helpful that is.
Well, negative ones would be very helpful.
Say that again, Art?
A negative test would really be helpful. Theoretically.
Yeah, I mean, for ABPA, we don't usually check SED rates, at least not to monitor ABPA, but my suspicion is you could definitely see a normal SED rate in ABPA, whereas you're right, it's generally going to be elevated in EGPA.
Matt, do you think it's adequate to, if you feel you have people controlled, that just mepolizumab alone is sufficient treatment?
Absolutely. Most of my EGPA patients, obviously there are the refractory ones who fail that, but most of them are controlled on mepolizumab alone. And that's what Wexler saw in that study, at least half, if not more, could be studied. It could be controlled with just mepolizumab. And this includes, people with significant myocardial disease. I mean, while it's true we generally see these people, as Anya said, from the inception with asthma, certainly, I get a lot of referrals for the more advanced disease, in particular cardiomyopathy. I've had a number of patients now, and most of them, and on some of them, I've had to up the dose. They're on, 700 milligrams of mepolizumab, but they do well.
Do you feel you have to get the peripheral eosinophil count to a certain level, low enough?
Yeah, probably. I mean, I don't know that there's any data saying that you need complete suppression, but my general feeling, like with HES or asthma, is that when you don't see complete suppression of eosinophils, then you should up the dose or maybe consider an alternative anti-IL-5.
All right, well, thank you, Dan. Francis reminded me we have to end on time because there's a faculty meeting and also board review for the fellows. So any other comments before we end? All right, thanks, everybody.
Thanks, Len.